I'm Lindsay Remy. I'm a sports orthopedic surgeon, and I'm excited to talk to you today about one of the really common injuries I see. You're probably watching this video because you or someone you love recently found out that they have an ACL tear. 1 in 3 people will actually tear their ACLs at some point in their life. This can be a really devastating injury for some people, and for other people, they tolerate it pretty well. So let's understand a little bit about what the ACL does first, and then let's talk about how it can be treated. The ACL stands for anterior cruciate ligament. It's one of the important stabilizers in the knee. It sits diagonally through the middle of the knee in a way that helps keep the tibia from shifting too far forward relative to the femur or thigh bone, but in a way that also helps control rotation of the knee joint. So it's especially critical in people that do pivoting sports or any things with sudden changes of direction. People that do more straight ahead sports, they enjoy cycling or walking, or just have a more sedentary lifestyle, are more likely to tolerate living without a functioning ACL. So when you come to the office after having been diagnosed with an ACL tear, that's one of the things we're going to need to talk about is what is the activity level that you hope to get back to so that we can decide if you're somebody that needs surgery or not. Once we've decided together that your ACL tear is going to be best treated with surgery, we need to decide the best manner to rebuild an ACL. And there are a few different ways to do that. Typically, I'm rebuilding the ACL out of your own tissue because your own tissue tends to heal more reliably into the bone and reduce the risk of re-tears. It is sometimes appropriate to use cadaver tissue, also known as allograft. This is usually a choice for people that are over 30 years old, are not planning on going back to high-risk cutting or pivoting sports, and mostly just need a stable knee for day-to-day life. Using cadaver tissue saves a little bit of surgical time and a little bit of pain from the surgical incisions of taking your own tissue. But for the majority of people who are going back to high-risk activities or who are younger at the time of their surgery, it is recommended to use your own tissue because that has the least risk of re-tearing in the future. There are 3 places that we can get your tissue to rebuild an ACL from: your quadricep tendon, your hamstring tendon, or the patellar tendon. The patellar tendon autograft option has been around for the longest. You'll hear it used the term BTB, which stands for bone, patellar tendon, bone. This is a graft choice that has a piece of bone and then a strip of the patellar tendon and then another piece of bone. This is a very reliable, durable option, but unfortunately it comes with a significant trade-off of pain when kneeling and a higher risk of arthritis under the kneecap down the road. The quadriceps autograft and the hamstring autograft are both very strong grafts as well. The downside to the hamstring is that you trade off a little bit of hamstring weakness over time, and some athletes are more likely to be weak in their hamstrings from the beginning and need their hamstrings down the road. So that may be a reason that I steer people away from the hamstring autograft. The quadriceps autograft is a newer choice that has really gained popularity in the last 10 years within the sports orthopedic surgery community, and it has become my favorite graft because it is very strong, very rigid, and yet does not have the significant pain at the site that the graft is taken from. You do have some discomfort at the area of the quadriceps where that piece was taken from, and you can have some weakness of the muscle while it's waking back up from surgery that happens, but people get back to a full strength in the long run. So I would love for you to talk to me about your questions or concerns about the graft choice specific to you. I do all of these for the right patient, but for most people, I think quadriceps autograft is an excellent choice. There's another way to help rebuild an ACL that is a newer technology called Bayer. This stands for Bridge Enhanced ACL Repair. And this is where I actually stitch up your own ACL over a collagen scaffold. Not everyone is a candidate for this, but it is something that I would love for you to bring up if you're interested in it. If your ACL tear happened very recently, then we would need to look at the MRI and see if you are likely to have enough tissue of your ACL left to consider stitching it back up into place. The benefit of doing a Bayer-style repair is that you don't have to have tissue taken from a different part of your knee to rebuild the ACL, and so you're able to preserve more of your own native knee function and what's called proprioception, which is the nerve fibers of the ACL have a role in helping your knee understand where it is in space. And so people who have the repair technique tend to feel a little more normal faster. There is some trade-off. This is a newer technology. It has not been studied for as many years. And so we don't know long-term yet if younger athletes are at higher risk of re-tearing. ACL surgery has risks, like all surgeries, and I just want you to know what some of those are. The risk of surgical site infection is thankfully very low. It stays around 1%. We do everything we can in surgery and after surgery to help minimize that risk. There's also a risk of blood clots with any knee surgery, especially one like this where you'll be in a brace afterwards. And in some situations, you may have to even keep your weight off of your leg, such as if you have a meniscus tear. Those two things, the immobility plus the active surgery, increases the risk of blood clots. The risk of blood clots with this specific surgery is about 0.5%. And I ask everyone who is safe to take aspirin to use a low-dose aspirin twice a day for the first 2 weeks after surgery as one way to minimize that risk. Another risk of ACL surgery specifically is the risk of knee stiffness. Around 5 to 10% of people may have to have some further intervention done to address knee stiffness. Another risk that I like to mention is numbness around the area of the incisions. This is actually so common it's hard to put a number on. It happens to at least half of people. It is usually temporary, and as long as you know that it's an expected thing, most people aren't bothered by it. The other risk is the risk of re-tearing your ACL. Unfortunately, that is the risk that is front of mind for me as your surgeon and for you as a patient, because this is not a surgery people want to go through more than once. This takes a lot of your time and energy, and we do everything we can working together to reduce your risk of re-tear. But in the scientific literature, that risk of re-tear is always there. The number depends on your age at the time of your surgery, what type of sports you're hoping to go back to, and what type of graft was used. But it's somewhere between 5 and 15% of people will re-tear their ACL even after a successful surgery and rehab. The number is similar to the risk of re-tearing your other side. Somewhere around 10 to 15% of people will have an ACL tear on the other knee, especially in that higher risk population, which would be younger females doing a pivoting sport such as soccer. The ideal timing of your ACL reconstruction relies on you having a knee that has very little swelling, good strength, and full range of motion. Typically, this takes 4 to 6 weeks from the time of your injury, but I've certainly seen patients that meet those milestones earlier and those that need a little bit longer. We really want to make sure your knee is in a calm, happy place inside before we put it through the stress of a surgery. Oh, ideally, we also wouldn't be waiting months and months, especially if you have any type of other issue. You have cartilage damage, meniscus damage, or a second ligament involved. That may push us to operate on your knee sooner so that you're not walking around with an unstable knee that could increase the risk of further damage being done. So let me talk you through a little bit of what to expect after surgery, knowing that the details for you may change based on what I see in surgery. Most people will need to be in a brace after surgery for about 6 weeks. The length of the time that you're in a brace really depends on how long it takes for your muscle function to return to normal. Everyone gets some muscle weakness after surgery. This can be really surprising because it can feel like your leg is really heavy. The muscles don't want to fire when you tell them to fire, and that's why you're starting in physical therapy right away. The brace is protecting you so that you don't fall until your muscles wake up. If you only have an ACL reconstruction surgery and I don't have to do another ligament or cartilage work or meniscus repair, then you're going to be able to put your full weight on your leg with crutches and the brace there to support you until you're strong enough. But for one of those other reasons, you may be non-weight bearing for a period of time. Most people then are getting stronger and back to more normal walking out of the brace from about that 6-week mark until about the 3-month mark or 12 weeks from surgery. Around the 3-month mark, most people are doing their day-to-day activities pretty well. They're walking comfortably, they have full range of motion, they feel good. In fact, this is the time point that I most worry about my patients because they tend to overdo it. They tend to feel overconfident and are more likely to try to play a pickup game of basketball or something that their knee is really not ready to do. Please do not play any pivoting sport. Don't try to run before you're cleared by your physical therapist. We need to take things slow. Around that 3 to 4 month mark, we're still focusing on you regaining your full strength and balance and understanding of where your knee is in space. And between the 4 and 6 month mark, depending on your individual details of surgery, you'll be ready to start running, and you might start some sport preparation drills. So these would be things like agility or getting a ball back in your hands or under your feet, but without intense pivoting and certainly without any competition. The return to sport timeline is going to depend on the details of your exact surgery and what sport you're going back to, as well as what your other risk factors are, including your age. But a good rule of thumb is to think about between 9 and 12 months is when most people are ready to return to sports. I'm a big believer in making that decision as scientific as possible. It isn't just the calendar that matters. It's, do you meet parameters that prove that your leg is as strong and ready as possible? And this includes having your physical therapist put you through some strength testing, balance testing, what's called hop testing, and some readiness surveys that help me make a scientific decision about if your knee is ready for surgery. I know all of this information can feel overwhelming. I hope that this gave you a good introduction. Please come to your office visit with questions, and I'm happy to talk you through the rest of it. See you soon.